Okay, here we are with the final psychopharmacology lecture. And I know we will be meeting again this Thursday, but this is the final video lecture. I wanted to use this lecture to discuss I wanted to end this course with having some serious discussion about whether the whole idea of depression, anxiety, schizophrenia, bipolar disorder, whether concluding that they are problems due to neurotransmitters, and that they are purely or primarily even physiological disorders, may actually be a myth, may actually be inconsistent with the evidence. Now, that would call into question something that's been taken as almost factual by the psychiatric community. But just because something has been really pushed by people who are set to make a lot of money from it doesn't mean it's accurate. So let's take a look at a few things. Now, there's some, and I'm going to get into the slideshow, and I know you're watching a lecture. There's a lecture, one of the videos that you're assigned to watch this week is actually called the neurotransmitter myth. But I want you to understand something right from the beginning. There is this assumption that because neurological changes, neurological deficit, neurological problems can be found in certain psychiatric disorders, that somehow that means that all psychiatric disorders are due to something neurological. So, for instance, because you can find neurological changes, neurological deficits, neurological problems in some of the more severe psychiatric illnesses like schizophrenia or bipolar disorder, that means across the board all psychiatric illnesses are neurological or primarily neurological and have to do with neurotransmitters. That actually is not necessarily the case. There is this one of the reasons why there's some real serious reason to question how much neurotransmitters do really play a role in the types of mental health problems suffered by millions of people across the world, is because there is this tendency to generalize or to group together that because depression and schizophrenia are both problems treated by psychiatrists, they must be due to the same factors, and that does not necessarily need to be the case. So you will notice that one thing throughout this course has been that one consistency throughout this course has been this idea that every time a psychiatric disorder has come up, there's an assumption that there must be a neurotransmitter issue involved with it, and that must be the primary cause of the disorder. And that does not necessarily need to be the case. Just because you can find neurological deficits as the primary cause in schizophrenia does not mean that that necessarily has to apply to clinical depression. And so there is a potential fallacy there because you are grouping together all disorders under the category of psychiatric disorders, and therefore assuming that neurotransmitters must be involved in all of them. Please keep in mind that throughout this course, what I have tried to get across to you, what I have tried to teach, both through my lectures, our discussions, and the materials that you've had through the courses, understanding how psychopharmacology works. And I think we've covered that in considerable detail. We've talked about how anti-anxiety, antidepressant medications, antipsychotic medications, and a number of other medications, how they all work when they are prescribed for individuals who have psychiatric disorder. But, and certainly that's something very important for a psychologist to understand, because many people that you see as a psychologist will be on some type of psychiatric medication. But what I wanted to end this course, and where I'm going with this, is you need to understand that just because billions and billions and billions of dollars are spent on psychiatric medication does not mean that that makes it correct, that all these medications are the primary answer for all of these disorders, because there are some real serious reasons to question that, at least for some of the disorders. And certainly as psychologists, that's an equally important question for us to keep in mind, as is how do psychiatric medications work. So the question, how do psychiatric medications work, is an important thing for a psychologist to know, but equally important, if not more important, is for psychologists to answer the question, is that really where the focus should be? Are these medications is trying to control the neurotransmitters in a person's brain really the primary focus of what should be done in order to effectively treat these disorders? And the question may very well be no. There are a lot of serious reasons to be concerned about how much psychiatric medications are emphasized. And certainly as psychologists, it's legitimate for us to ask the questions. I mean, it's actually quite sad from my perspective how many psychologists I meet who really do give preference to the idea that medications are the primary way to treat individuals who have psychiatric disorder, because these are individuals who can't prescribe the medications. They are trained to understand and treat psychiatric mental health disorders without the use of medication, yet they are very focused on medication being the primary way that treatment should be given for individuals with mental health disorders. So as psychologists, we can't prescribe the medications anyway. So it would be expected of us, or we should at least expect it of ourselves, to have a questioning attitude towards how much medication should be emphasized in treating mental health disorders, because otherwise, what are we doing in this profession? Why be in the profession that is focused on treating mental health disorders when we could not provide the primary way of treating that disorder, those disorders? So as psychologists, I think it's important for us to know how psychiatric medications work. It is equally important for us to know why there is reason to question how much those medications should be emphasized. Now, I also want to go back to this issue of, it could very well be that certain categories of mental health disorders maybe have more of a reason to have an emphasis on medications than others. The example, of course, being schizophrenia would be a good example. Schizophrenia is seen as being primarily a neurological disorder. So the idea that you would have medication primarily designed to control some parts of how the brain functions in individuals with schizophrenia would be expected, because it's considered to be primary neurological. It's actually not even, I mean, it's considered to be psychiatric, but in a lot of ways, it's primarily considered to be a neuropsychiatric disorder, meaning that the real emphasis is on is on the neurological part. So individuals with schizophrenia, their brain does not function the way other people's brains do. So that is a clear-cut distinction of schizophrenia. So the focus on medications there certainly would be warranted. But it is not as clear-cut the case that individuals who have depression and anxiety, that their brains work differently. There is some evidence to suggest that controlling the dopamine or the serotonin or the norepinephrine in individuals who have anxiety or depression helps to lessen the severity. But it is not very clear why that happens. It happens in schizophrenia. There are very clear ways that the brain is functioning different, but those differences are not as blatant in things like depression or anxiety. And where they are evident, it's not quite clear whether, it's the chicken and the egg thing. Did the change in the brain occur prior to the person developing? In other words, were they the cause of the depressive symptoms? In other words, you had the brain changes and those led to depression and anxiety, which would be sort of the psychiatric model. Or is it possible that there were the changes first? The person was having difficulties dealing with stress, was having a major degree of negative thinking and negative view of themselves and the world, and that led to the neurological changes. So the neurological differences between individuals with depression and people without depression, people with anxiety and people without anxiety and people with anxiety, are much more subtle, are much more varied, or much less clear than are the differences when comparing brains of people with schizophrenia and brains of people without schizophrenia. So the changes are much more severe in the psychotic disorders. Now, it's also worth keeping in mind that when we talk about how this idea of neurotransmitters being the key, in other words, and that leads to medications, it is also important to keep in mind that one prominent mental health disorder, autism, is by definition a neurological disorder. It is called a neurodevelopmental disorder. The DSM-5, it is a neurodevelopmental disorder, was under that category. Yet there is no medication for autism. So there are really two areas that we look at. There are other areas, two major areas to look at when questioning whether this emphasis on neurotransmitters may be overblown when it comes to understanding mental health disorders. One is that at least in many of the mental health disorders, anxiety and depression being two very clear examples, is not clear if the differences that occur in the brain, whether it's the brain structure or the level of neurotransmitters, whether that is a cause of the depression and anxiety, or whether it is a result of the depression and anxiety. The other avenue is that just because you can identify brain differences does not mean that the major way to address them is through the use of control of the neurotransmitters. Because there's a lot of ways that the brain functions. The brain functions by certain areas of the brain responding to stressors and to incoming stimuli in certain ways. So the brain area responds. It then sends out, those areas then send out neurotransmitters, and those neurotransmitters are then received by other parts of the brain. The assumption with psychiatric medication is that by controlling those messages that are sent out, you can control the symptomology. That is not necessarily how it has to be, and it certainly is the one that's given prominence. But just because it's become prominent doesn't mean it's correct. There is a joke that I bring up a lot in different courses, especially when talking about medications and stereo medication, which is the old joke of there's a man searching under a spotlight for something. Another man comes along and says, "What are you doing?" And he says, "I'm looking for my keys." And the man said, "Oh, where'd you lose them?" And he says, "I lost them over there." He said, "Well, why are you looking over here?" He said, "Because of the lights. I'm looking over here because the light's better." That sometimes is reflective of the possible difficulty with the neurotransmitter explanation. Is it could be that because neurotransmitters are something that are understood better, can be controlled better. One thing we didn't get into is the chemistry of all this, but psychopharmacology by definition emphasizes the chemistry of the brain and tries to have some control over that. We know a lot about the chemistry of the brain. We know more about the chemistry of the brain than we do about the neurology of it and the physics of it. And certainly we know much more about the chemistry of the brain than we know about the connection between the brain and the mind, the brain and consciousness. The brain is this instrument that has a whole lot of chemical firings and a lot of electrical impulses. We know quite a bit about that. And we know certainly more about the chemistry than we even know about the physics of it. And like I said, the whole connection between the brain and the mind and sort of this more esoteric psychological, possibly even spiritual aspect, all those aspects of the brain, we know very little about that. So it is quite possible that the reason that neurotransmitters are emphasized so much, and there's so much emphasis put on medications, is because it emphasizes chemistry, and we actually know more about the chemistry of the brain than we know about anything else. That doesn't make it the answer. Just because it's the answer we know doesn't make it the right answer. And that's something, that's a point I guess I want to really emphasize here. Psychopharmacology takes advantage of the area of the brain we probably know the most about, which is the chemical makeup, how the chemistry of the brain works. But that doesn't, just because we are using the information that we know the most about, doesn't make it the right answer. Again, going back to the joke of the lamp, the light. Are we actually looking for our keys where they really are, or are we just looking for our keys in the place where the light is better? And are we emphasizing psychopharmacology because it really is the answer to understanding how best to help people with mental health disorders? Or are we emphasizing it because we know the most about it? I also want to, before I get into the slides I have here, I also wanted to talk about the issue of how I brought this up earlier in the course, and it's what I want to stress again. Psychiatric medication is the one category of medication that limits how much is required in terms of explaining why it works. An antidepressant can get approved by the FDA not by showing that it can get approved by the FDA by showing that it helps lessen depression. However, there is quite a limit placed on how much the scientists developing it have to show that they understand why it works. They may have theory, they certainly would have theory behind why it works, but they don't have to show convincing proof of why it works. So psychiatric medications just have to show that they work. They don't have to show why they work. And that can be another sort of statement against emphasizing how important medications can be, because there is no clear, there really is no clear evidence in any research on any psychiatric medication, with the possible exception of schizophrenic antipsychotic medication, that the medication is treating the primary problem that the person is experiencing. It is treating an issue, the neurotransmitter difficulty, but there is no clear indication that that is treating the primary problem. It may be simply treating an offshoot of the problem. It may be treating one aspect, it may be treating one minor aspect of the condition. We just don't know. And certainly, given what we've talked throughout this course about the severity of side effects that can be experienced by people who are taking psychiatric medications, it certainly is very important to at least continue to question whether this model of controlling neurotransmitters as a way of treating mental health disorders, if that really is the primary route that we should be taking. All right, I want to share my screen here and show you some slides on the topic of the chemical imbalance myth. But are neurotransmitters directly linked to minor personality disorders? And in this context, the author of these slides, the professor was giving these slides, by minor personality disorders is talking about things like depressive disorder and anxiety disorders, as opposed to more severe disorders like schizophrenia. And hold on one second here. Okay, the slides are kind of small here, and I don't know. I'm not able. I'm going to read them because they may be a little hard to talk about, but I want to go through. So hopefully you can see the slide, but I'll point out the most important part there. The theory of a chemical imbalance here. Oh, sorry, excuse me, sorry about that. I got to. I thought that was, you know what, I thought that was a thing to increase the. Hang on one second. I apologize here. Okay. So here are some things. So what is this idea? So the idea of a chemical imbalance, the theory of a chemical imbalance being the source of psychiatric illness, is that the theory that there is a neurotransmitter imbalance between synapses of the brain regarding uh, resulting in a psychiatric disorder. Now, there are a lot of theories that we've talked about throughout the course. The most common is the serotonin theory of depression. The concept that depressed patients have a lower than normal level of serotonin between the synapses in their brain. And so the depression is occurring because of that lower than normal level of serotonin between the synapses of the brain. Now, so that is the chemical imbalance theory. That this theory of the most common of these theories that the concept that depressed patients have a lower than normal level of serotonin between synapses of the brain. We talked about that. That is one of the major theory underlying all the antidepressant medications, or not all of them, but a large number, SSRIs. And so what happens with SSRIs is they keep more of the serotonin out in the brain by preventing it from being taken back up into the cells. But notice, and this is where the opposite of these slides go, notice with some of even the press releases, even the things that the chemical companies put out about these medications. While the brain chemistry of depression is not fully understood, research suggests that depression is caused by an imbalance of certain chemicals in the brain. So notice how even, and you can read the other one, depression is not, this is for Prozac, depression is not fully understood, but a growing amount of evidence. So notice that each of these press releases from the materials used to sell the medication to medical providers, notice that, excuse me one second here. Okay, hold on one second. Okay, I'm back. Hang on a second. I apologize. I don't know if you knew this, but with Zoom, if I have to pause for a second, I can't keep it on share screen. So now I'm going to go back. Okay, so where I was going with this is, if you notice, even from the press releases, even from the things used to sell these medications, they say things like the chemistry of depression is not fully understood and depression is not fully understood. Okay. Here, and this is what the these are the press releases that were in the previous slide. Notice some of the words there: not fully understood, thought to be, maybe, not fully understood, maybe. These are words that were in those slides, in those press releases. Just these words, it's useful to keep in mind the words that are emphasized: not fully understood, thought to be, maybe. Now it's interesting to go through some of the history, and we talked about some of the history before, but to go through some of the history and more critical, with more of a critical eye. So in the 1960s, there was a drug, racipine, used in animals. It was found that it was found that the animals became more active when given the medication. It was also found that it depressed the function of serotonin and norepinephrine in the brain of the animals. I'm sorry, no, the drug led to the animals becoming inactive and was associated with them also having less serotonin and less norepinephrine. And so the assumption was this was what was happening in depression, but what was overlooked, and this is in the early days of developing antidepressants, was that the same drug given to humans didn't lead to depression. So, you know, there was always this question of, is inactivity lower functioning in animals really equivalent to depression as it occurs to human. That's really been an argument throughout a lot of animal models, is that um, it's been equated that uh, inactivity and unresponsiveness in animals is consistent with what we call depression in humans. But whether that's actually accurate or not is up in the air. It's not quite clear that animals who become inactive and unresponsive are necessarily what we would call depressed. Here's some other studies from 1996 at Yale University. Basically not supporting the whole idea of serotonin being directly related to depression. There's been a lot, basically what's going on here is there's been a lot of research countering this idea of serotonin and norepinephrine levels playing a major role in depression. But that, for a lot of different reasons, that hasn't got as much emphasis. So I guess what I want you to take from this whole idea of serotonin, dopamine, and norepinephrine being heavily involved in depression and anxiety. It's not been found in 100% of the research. It's not like it's a done deal that the research support that, although from hearing how medications are presented, it would be an assumption that it's been strongly emphasized. And here's just a lot of other examples of that. Then there are also okay. Basically, one of the biggest questions in this idea of thinking that the chemical balance may be a myth, meaning that that may not be the cause of psychiatry, is this issue of correlation, not causation. When there is found that individuals have a certain lack of neurotransmitter in their brain, and then also has depression, is that a causal factor or is it correlation? Are they both being caused by the same thing? One example, is it possible, and there's some evidence that suffering a stressor like loss, fear, hostility, or trauma could lead to less serotonin in the brain and also lead to depression. In other words, it doesn't have to be that it's causal, that the loss, fear, hostility, or trauma leads to a lack of serotonin or a reduced level of serotonin, and that leads to depression. It could be that the loss, fear, hostility, and trauma cause both a reduction in serotonin and depression, the two not being directly linked. So there is no, so the bottom line, and this, I'll just go back to this one. Depression and anxiety have no evidence of either causing a chemical imbalance or in humans, nor is there direct evidence of the chemical imbalance causing depression and anxiety. All that's been proven is that there's a correlation, that they both exist, but it's not necessarily causal. And then here's sort of a criticism from a very famous book called "Your Drug May Be Your Problem." In animal research, all psychiatric drugs directly affect the brain's normal chemistry by disrupting it. So what ends up happening is what ends up happening with this is that it basically could be that the um, uh, that the overabundance of serotonin that comes into the that hasn't been made lead it to lessen the response that the brain has to serotonin, and that could actually be happening more problematic. So the bottom line of this whole argument is that um, the overabundance of serotonin may actually be impacting the brain's ability to properly respond to serotonin. And it may be causing more problems than it's helping. It could be affecting DNA. So there's a lot of really strong, not only side effects, but it may actually be impacting the brain's development and the brain's ability to respond to serotonin, which may be why over time people have less and less response to the chemicals that they take, which means they have to take more and more of the chemical. So you hear that people are antidepressants, the antidepressants keep getting increased. It, this is a good way to put it from this author, Joanna Moncrief. In short, psychoactive drugs create a new chemical balance that alters normal behavior of the brain, much like alcohol may inhibit our motor functions. So that's a real area of concern. There's a real reason to be concerned that that not only are there side effects associated with psychoactive drugs, but psychoactive drugs may actually be changing the brain's chemistry and the brain's ability to respond to certain chemicals. And that in and of itself may long-term impact how the brain functions over time. And that may have some more long-term effects that may be more problematic and may outweigh the level of problems associated with the initial mental health disorder. Okay, and then this well, this is a number of years ago, but bottom line of all this, there really is no way to test for a chemical imbalance. So it's not clear that the chemical imbalance that is usually stressed to explain what these drugs are doing, there's no way to test for that to prove that it's existing and to prove that it's on a correlation rather than causation. And then of course this last point is why is it emphasized so much? And certainly the bottom line of that is there's a lot of people making a lot of money on this idea that there's a chemical imbalance. So, and then you have the other video that I gave for you to watch, the YouTube lecture, again on the chemical imbalance myth. So I wanted to leave. We can certainly pick this up on Thursday, but I really wanted to leave you with this idea that just because you now understand more than psychopharmacology, I really do not want you to take from this course that has to be the answer. There are a lot of problems with the assumptions made in psychopharmacology. And there is a lot of reason to think that even though certainly psychopharmacology can be very helpful in many cases, that there is a lot of reason to think that it's strongly overemphasized. And that maybe this idea of this chemical imbalance is not really an explanation and more a reflection of correlation rather than causation. Okay, I look forward to seeing you on Thursday. We can discuss this further.